आइज या वाइट इन्फ्लेमेशन भी लेवल करते हैं क्योंकि आइराइटिस होता है बट कंजेशन और रेडनेस नहीं होती तो इट कैन इजीली बी मिस्ड। इसलिए इनकी जो स्क्रीनिंग है वो रेकमेंडेड जो पीरियड है उसमें होनी चाहिए और जितना यंग एज होती है उतना ही ज़्यादा रिस्क होता है ऑकुलर इन्वॉल्वमेंट का।
So anybody else who wants to add? Important features को बता देंगे प्रोफेसर ने। The presentation is in juvenile group, pediatric group may be systemic, which is called stage disease. Juvenile rheumatoid arthritis patient presents with fever, rash, hepatosplenomegaly and lymphadenopathy. And there is less involvement of joint, there is less involvement of eye. The second mode of onset is polyarticular. When more than 4 joints are involved, the incidence of uveitis is less. So, third variety is quasi-articular, which is now known as oligoarticular in American terminology. In oligoarticular juvenile idiopathic arthritis, the joints involved are 4 or less in the first 6 months. So this is the variety which is mostly related with uveitis. Now the problem is that the uveitis is chronic, insidious, as Dr. Fizar said, the eye is white. Frequently it is missed. जब तक आप स्ट्रीट लैंप पे बिठा के you will see for the cells and flares, you will not be able to pick. And to pick early reaction, you have to switch off the lights, you have to increase the magnification, you have to increase the illumination, and then you will see a reaction of +1, 2. Right? Because of the chronic inflammation, the complication rate is high. Mostly the vision deterioration, inflammation is missed in children because they are not seen thoroughly. They present with band keratopathy, cataract, glaucoma, cystoid macular edema, or phthisis. So these are the complications which are associated with chronic inflammation, and these are more common in juvenile idiopathic arthritis. So we frequently see the follow-up is more rigorous, especially in patients of oligoarticular or quasi-articular disease, which have ANA positive, anti-nuclear antibodies. So we check up these patients after every 3 months. Who are ANA negative and polyarticular, we can see them after 12 months. But in quasi-articular, with the ANA positive, this is frequently a MCQ question that in quasi-articular ANA positive, what is the frequency of follow-up? So this is the 3 months follow-up, which is the most rigorous one. Now to control the inflammation, you can use all the modalities which you do. And it is better to switch to the immunomodulator therapy early because the corticosteroids have their side effects, especially in children. Retardation of growth in case of systemic corticosteroids and cataract and glaucoma in case of ocular steroids. So the drug of choice is methotrexate. Immuron azathioprine has also been used in such cases. It is better to involve a rheumatologist when you give immunomodulator therapy. Right. So what is the differential diagnosis? What is anesthetic?
Ligaments or tendons की insertion pain.
And Fuchs heterochromic arthritis. So all the chronic inflammatory diseases come in the differential diagnosis where the inflammation is not very marked. So, psoriatic arthritis. What are the features of psoriasis? When a patient of uveitis comes, what are the common symptoms? Patient complains of photophobia, pain, watering, redness. What is the type of redness? Circumcorneal. So, in acute anterior uveitis, the circumcorneal congestion. What is the difference between circumcorneal congestion and the congestion which is more marked in the cornices? One is location, of course, and any other difference? Mostly, this gives a violaceous hue because the deep vessels are also involved. In conjunctivitis, the superficial vessels are more involved. So this is called ciliary congestion. So the fresh trainees, what are the different types of KPs? What are KPs? Keratic precipitates. What are these? Deposits on the cornea. Good. What deposits? Pigment deposit can be one type, but more frequently these are inflammatory cells. Inflammatory cells are deposited. So what are the different types? Fine KPs. Okay. Mutton fat KPs. What are mutton fat KPs? Large ones. Okay. Any other terminology which you can use with stellate? Okay. Star shape. Any other? Pigmented, non-pigmented, hyaline. So these are. Then there is distribution of KPs. What are the possible scenarios? Either they are located in a triangular fashion with the apex toward the corneal center and more in the inferior corneal periphery. They sediment down. This is one pattern. Another pattern is they are distributed evenly on the corneal endothelium. So which is the disease in which these are randomly distributed all over the cornea? Oaks. Good. So these are the common features of uveitis. You see, my long case was on uveitis, and if you give a detailed description of what is the flare, how many cells are present, where is the distribution of, I still remember I said there are about 15 KPs which are present on the inferior cornea. So the examiner is satisfied. Okay, he has given all the details. Then they are not going to ask you many questions. Okay, so whenever there is anterior segment inflammation, what are the consequences on the iris? What changes in the iris occur? Loss of crypts. The fine details on the iris are disappear, and this is called washed out appearance. You see, the iris becomes muddy as it has been plastered and the details are lost. So this is one. Any other finding which you can expect in iris? Synecdoche formation. What is synecdoche?
So it is the attachment of iris to the lens or the cornea. Anterior over the cornea से attachment to posterior over the lens.
कोई उनको ठीक है. So anterior synechia are usually called peripheral anterior synechia (PAS), where they close the angle, and the posterior synechia are usually central. What is a consequence of posterior synechia. Sorry, pupillary block. So the pupillary block occurs. There are two terms, seclusio-pupillary and occlusio-pupillary. So in one is there is formation of a membrane on the pupil, and the other there is 360-degree synechia on the pupillary margin, which leads to retardation of flow from the posterior chamber into anterior chamber, and the iris blows at early. This is called iris block. Okay, start please.
Into oligoarticular, polyarticular, and systemic involvement. Oligoarticular is the most common form in which 4 or less than 4 joints are involved. Knees are most commonly involved, followed by ankles and wrists. Girls are affected 5 times more than boys, and peak age of onset around is 2 years. About 75% of children are anti-nuclear antibody positive. 20% of children in this age group have uveitis. Anti-nuclear antibody is a strong risk factor for the occurrence of uveitis. Second form is polyarticular, that is more than 4 joints involvement, 5 or more joints involvement. It is subdivided into 2 categories, rheumatoid factor negative and rheumatoid factor positive. And rheumatoid factor negative, it is typically both small and large joints are involved, and it is symmetrical. Symmetrical involvement of the joints is occur in this form. Female to male ratio is 3:1. That is, in this group also females are more involved. Disease occur at any age group throughout the childhood. Fever and rash may occur. 40% of children are ANA positive, that is anti-nuclear positive. In that group, 75% of children were positive. In it, 40% of children are ANA positive. Uveitis occurs in 5 to 10% of cases. Second form of the polyarticular is rheumatoid factor positive. In this, again, 5 or more joints are involved, but it resembles adult rheumatoid arthritis. Its features resemble adult rheumatoid arthritis, and it has very low risk of uveitis. Systemic disease is also known as Still's disease. Systemic features include fever, episodic erythematitis, maculopapular rash, lymphadenopathy, hepatosplenomegaly, and then arthritis. Equal frequency in boys and girls in systemic disease occur at any age throughout childhood. A majority are negative for anti-nuclear antibody, and uveitis is rare because more of them are negative for ANA. Other form is enthesitis related, that is, enthesitis means inflammation of the connective tissue with the ligaments and bones, ligaments and tendons attached to the bone. At that side, the inflammation of that area of the connective tissue is known as enthesitis related. Other form is psoriatic form, and the other which skin is also involved, and the other form is undifferentiated. These 3 forms, that is enthesitis, psoriatic, and undifferentiated, are very less commonly seen, and the first 2 have more risk factor for uveitis, but the last one, that is undifferentiated, has very low risk for uveitis. This is a child showing the inflammation and swelling of the knee joint. This is swelling and inflammation of the small joints. This is the maculopapular erythematous rash. This is again rash on the face. Systemic disease can be seen. Juvenile idiopathic arthritis is when to polyarticular, that is oligoarticular, polyarticular, and systemic onset. Polyarticular, again, seronegative and seropositive, that is RA factor negative and RA factor positive. 7 types of juvenile idiopathic arthritis: systemic, oligoarthritis, polyarticular with negative RA factor, polyarticular positive RA factor, psoriatic form, enthesitis form, and undifferentiated. Anti-uveitis, main cause of morbidity in juvenile idiopathic arthritis is anti-uveitis. It is particularly dangerous because it is asymptomatic. The child does not say to their parents that we are suffering from anything. So it is usually detected by screening on slit lamp examination. Even during acute exacerbations with anterior chamber full of cells plus 4 aqueous flare, cells, it is rare for patient to complain. Sometimes patients say that there is blurring of the vision, but usually there is no complaint from the patient, from the children. Often uveitis may not be suspected until the parents recognize the complications like strabismus, abnormal ocular appearance like band keratopathy or cataract. Then they bring the child to the doctor. Injection, that is conjunctival congestion, usually is mild. Even in presence of severe uveitis is usually absent or mild. Inflammation, it is a type of chronic and non-granulomatous inflammation in this type of juvenile idiopathic arthritis. Both eyes are affected in 70% and it is symmetrical inflammation, symmetrical severity of inflammation. During acute exacerbations, that is entire endothelium shows dusting. All of the endothelium occupied by the babies and shows dusting by many hundreds of cells, but havepion is absent. And posterior synecdoche, it is common in long-standing and undetected cases. Band keratopathy, cataract, secondary glaucoma, and myopia may occur because of the cataract formation, synecdoche formation, maculopathy like cystole macular edema, epiretinal membrane, and cyclitic membrane and thysis. These are the complications or consequences of the juvenile idiopathic arthritis. This is usually not present, but sometimes it is present. It appears as like this: conjunctival congestion. This is band keratopathy. Again, band keratopathy. This synecdoche formation in prolonged and undetected cases. This is a mild inferior synecdoche formation in the initial cases. This is cataract formation. Prognosis in 10% uveitis is mild. That is not more than +1 cells can be detected in the anterior chamber, and it persists for less than 12 months. Whereas in 15% patients have one attack which lasts for more than 4 months, lasting less than 4 months, and which they are +2 to +4 aqueous cells. The 10% में mild है और वो less than 12 months में subside हो जाता है. 15% में जो है वो one attack होता है, वो less than 4 months में होता है, उसमें +2 +4 cells. 50% cases uveitis is moderate to severe, it persists for more than 4 months. And in 25% uveitis is very severe, it lasts for several years and responds poorly to conventional treatment, and it is responsible for more the morbidity. Investigations we do in juvenile idiopathic arthritis: systemic diagnosis and management. The patient should be performed by a pediatric dermatologist, so proper treatment should be started. Anti-nuclear antibody, it is a positivity of this ANA denotes an increased risk of uveitis. Actually, this is an investigation which we can go for. Actually, B27 testing, it is useful in differential diagnosis. It is, if present, it is a strong indicator of uveitis. Rheumatoid factor, it is again useful in differential diagnosis. How we can screen the patients? Screening is very important. Because it is usually asymptomatic. Initial examination within 6 weeks of first diagnosis of juvenile idiopathic arthritis. Visual symptoms, that is if the doctor, the rheumatologist our parents see visual symptoms like synecdoche, cataract, band keratopathy, they should be urgent slit examination within a week. Initial 2 monthly examinations for 6 months and then followed by 3 to 4 monthly intervals. High risk factors include presence of anti-nuclear antibody because they have high risk of uveitis, and onset before 7 years of age and female gender. They are high risk factors. Before 7 years of age, onset, female gender, and presence of anti-nuclear antibody. Information for parents on when screening, when we are starting patients from the screening, then we should inform the patients, we should guide them that they should seek urgent advice for any visual symptoms. When our child is saying that there is something coming in front of my eyes and floaters, ocular redness, clouding, abnormal pupils, then she should come to the doctor again. Self-monitoring, check monocular vision at least once a week and attend an optometrist annually. It is after the screening period is over. And we see that there are no more symptoms going on, then we discharge the patient from the screening, and then we say to guide the patient or parents of the child that should self-monitor the parent. They should monitor the child by monocular vision and checking at least once a week and attend an optometrist annually. Differential diagnoses include idiopathic juvenile chronic arthritis, in which only eyes is involved, so there is no systemic involvement. Juvenile reactive arthritis, juvenile inflammatory bowel disease associated arthritis, juvenile sarcoidosis, Lyme disease, intermediate uveitis, and masquerade syndrome, retinoblastoma involving causing the uveitis. Treatment include topical steroids. This is initial treatment. First we start from topical steroids, mydriatic agents. Mydriatic agents should be given very with caution to the children. We should give them initially and then taper them off, and then don't give them for prolonged time because they can cause amblyopia in children. Periocular steroids, if there is no improvement with the topical steroids, oral steroids in resistant cases and severe cases, NSAIDs for the joints and systemic involvement. Systemic immunosuppressive agents, they have a very good role in systemic involvement. Methotrexate, infliximab, and adalimumab. These are some names of systemic immunosuppressive or immunomodulatory agents. Secondary glaucoma is controlled by topical intraocular pressure lowering medications. If still it is not lower, then we can go for trabeculectomy with mitomycin C. It has good effects. And if the patient is receiving antinuclear factor for systemic involvement, then it gives more good results. The trabeculectomy with mitomycin C. And glaucoma balls can also be used in persistent higher intraocular pressure patients. Cataract extraction, if there is cataract formation, then we go for cataract extraction for the better visual outcome. There is some treatments, first line treatment, NSAID, second line for systemic involvement, then high dose systemic corticosteroids, third line treatment anti-tumor necrotic factor. This is for systemic involvement.
You can expect a good prognosis. So you have to increase the steroids or immunosuppressive drugs, treat the inflammation aggressively, and there should not be inflammation for 3 months, then you go for surgery. If you do not control the inflammation or you go for surgery earlier, then post-operatively there is formation of inflammatory membrane, severe reaction, and then it is difficult to control. So now, because if you do not implant lens, there are more chances of having amblyopia. Intraocular lens prevents amblyopia. So now people are more recommending intraocular lens, especially the acrylic one, after controlling the inflammation. So, the screening of the pediatric population is very important. You see, as a doctor, we also have a responsibility of advocacy. Advocacy is making the public aware of diseases. So whenever I encounter a headmaster or a principal, I encourage them that they should get screening for all the students of their institution. In the West, there is a compulsory eye screening in the schools. At 1 year, first year, or 5 to 6 years of age, all the children undergo eye examination. So they pick up those patients who have decreased vision, and these are referred to eye specialists. So I volunteer the principal that you can send somebody to us, any teacher, and I will tell them how to test the vision. I will also give them 1 or 2 Snellen charts. You can hang up in any room and test the vision yourself. And whosoever has decreased vision can be referred to us. I think we should also encourage the schools in the vicinity. हाँ वो मतलब है हम कोशिश करते हैं कि स्क्रीनिंग जो है उनको सिखा दें और जो जिसका प्रॉब्लम है वो हमारे पास आए ताकि स्क्रीनिंग में हमारा टाइम ना जाए। एक टीचर को सिखा दें तो वो काफ़ी होता है। सो हाउ डू यू ट्रीट बैंड केराटोपैथी?
Chelation.
Good. Which agent is
EDTA.
EDTA. Good. So you can remove the epithelium and apply that, and the calcium is dissolved. Next, it is done if you expect some improvement or visual improvement or cosmetic improvement. If the eye is already in phthisis, then there is no fun of it. So anti-metabolite treatment, as I said earlier, this is very useful in sparing the corticosteroid use so that the toxicity is reduced. So you have to take liaison with a pediatric rheumatologist who usually monitor these drugs. Any comment? No? Sir.
Usually breast issues with the